I think our youth and adolescent that are under, which I'm going to really judge is under the age of 25, really should be and ought to be among the highest, if not the highest priority that we give to a patient population in addiction medicine. With the only other competing factor in my mind is a pregnant woman asking for help. And we're going to go through some of those rationales on why. But as I just as far as disclosures go, I do have a variety of government funding. And I'm going to try to avoid trade names, but I have the tendency to use words like Brixadi, Sublocade, Suboxone, Subutex, as opposed to saying, um, you know, the long-acting injectable buprenorphine product or buprenorphine with or buprenorphine without, just because I think it helps communicate things to you clearer. However, if you find any biasing or anything, please feel free to include that in the chat. With that, I want to talk about some of that neurobiology of the adolescent mind, how it's growing, how it's developing, how that's going to impact and both them and ultimately how that's going to have a long-term, lifelong impact on them and going to set them up again for the children of them. I want to discuss some medical interventions, and we're going to focus that on the adolescent population. So I think probably the best place to start is the Monitoring the Future report. If you're not familiar with this, this is a report since 1975 that has been published currently, and it's changed over the years, but the University of Michigan is currently the one who oversees and publishes this, and it's funded by NIDA. This is a survey of about 25,000 8th, 10th, and 12th graders, and it has been over nearly 50 years that they've been publishing this report. It gets published at the end of the year. Has been very highly predictive at looking at drug trends in the United States and being able to predict that. This is their big chart and their big time to be able to gather this information. And I think the report published in 2024 really goes up to 2023 data. And in that, we had the biggest decline in addiction with our use in the entire history of this report being generated. I think that's wonderful news. And I think, we should really be saying, hey, there is some progress. There is something finally that is happening. Now, we'll see how that bears out. The further detail on how everything is broken down, I'm just going to kind of break some of this out and looking at the illicit drug use of marijuana and inhalants, and we're seeing illicit drugs, marijuana is going down a little bit, and I think this is at a national level. I think more research and would be curious to see what all variety of states and our different targeting approaches are being done. I think, there is evidence that the DARE campaigns, unfortunately, an absence-based model just isn't quite working. So the other thing, as we start getting into positive results of like alcohol and cigarettes and vaping are also declining, I think as somebody who, I'm not a formal epidemiologist, but somebody who does a lot with numbers, I want to see a sustained remission, and I want to see this over 2, 3, preferably 3 years to really say that this is definitely real. But again, in the addiction world, sometimes it's fun to share new and other experience. This is from the New Mexico Department of Health, and looking at when are people overdosing and dying, and at what age categories. And I think it's important to, and it's a little bit, to me, subtle, and you don't pick up on this, or the average person doesn't, but the times or the peaks in both men and women that are going to be in fatalities are the years in their 20s, 30s, and 40s, maybe into the 50s. Those are the years that parents or I guess we as adults are parents, imprinting on our children. it oftentimes isn't somebody who uses for the first time who overdoses. It is somebody with a substance use disorder and takes some time to develop. And again, remember this is imprinting. So this is one of my more favorite, or one slide out of one of my favorite talks to put together and understand the financial driver between selling fentanyl. And this was a project that I did in putting together with a business plan with a $10,000 investment that I can get a kilo of fentanyl that's going to translate into 1 million, 2 million pills. I recognize we're no longer in the $20 a pill um, era, and we're in, $5 street value. But adjust the numbers as you seem fit. But on a $10,000 investment, if I'm taking home $1 million on that, there's nothing in business that's like that. And when you go to a teen and somebody who's, trying to get a car for the first time, like, how am I going to pay for that? How am I going to do this? Those are people who, we'll get into some of the neurobiology of the brain, but they're highly recruitable and easy to get into a selling in a type business. The use of social media, and things like Snapchat and others that intentionally delete your chats from their server and on your phone within a couple of days, to get rid of incriminating information, also work as great platforms for the distribution and sale. What we've seen, and this is a little bit dated from 2023 and coming from the DEA, is that a lot of emojis are used to basically brand or to let people know that they're selling drugs online. Um, Again, this can and no longer does a 15-year-old or 14-year-old need to stand in the corner of Central and San Mateo, is they can do this from the comfort of their own home while mom and dad are home at the same time. And I think a lot of parents are not of any of the wiser. This is one of my favorite slides in understanding addiction and the neurobiology, going through a positive reinforcement pathway where we get a dopamine release, we get into the nucleus comes in the brain. And I think it's important to recognize both for the negative and the positive reinforcement pathway that these occur in the brainstem, or more of a what we want to say primitive version. That just means that we just don't have intellectual thought over this. We just know, hey, that felt good. I want more of that. We like it, we want it. And they seek out and they do more of it. And I think we've all had when we were going to college, and I'll speak for um, my personal experience. Those friends who you're in the dorm together and they partied a lot. The other that I have found to be critical important to understanding addiction is going to be this negative reinforcement pathway, developed through the amygdala. This is going to be our fear, our distress, our anxiety, and we want to motivates us to avoid things. And so, a lot of our patients, they use substances to avoid having to deal with issues in life, and we see this with teens, and we're going to talk about this, and with some of our coping mechanisms. And when a teen or a young adult to start using, as it oftentimes becomes part of a coping mechanism for them. And so when we fast forward this 20 years in the future, and that 15-year-old is now 35, they oftentimes are left with the coping skills of a 15-year-old. And so as part of my addiction treatment in somebody at 35, I'm recognizing that developmentally they may have coping skills that are really lagging behind what would be age appropriate for them as well. So this is some of Somerville's work, that about 10, 15 years ago, he really started developing or publishing and identifying how the brain in children and transitioning to adolescent works. So we get the PFC is prefrontal cortex. That's going to be our thought. That's, says, hey, maybe this just is, this sounds really fun. Um, to, I don't, to go skydiving. But hey, we should ask some questions, about them. Just make sure that this is a safe group to go skydiving with. That whole thought process comes from the prefrontal cortex. The striatum is going to be more of that deeper brainstem, where we say, hey, kind of comes with impulsivity. And in children, we've got a balance between the prefrontal cortex and striatum. However, as we transition into the adult brain, the striatum develops more rapidly than the prefrontal cortex. And that results in that impulsivity that we associate with adult or with adolescent mind. And it isn't until we get to about the age of 35, or excuse me, 25, when the prefrontal cortex really um, forms well, and we've got real structure to that adult thinking, which I think is also important when when we start considering, the legal age for drinking in this country is 21, and having an additional 3-year gap between when you can have a cigarette or you can join the army and when you can legally buy a beer or a bottle of Jack Daniels. I think that 3 years allows for an additional 3 years of that prefrontal cortex to grow. And also, when we start looking at risk factors for when we develop a substance use disorder, a fairly reliable, pretty good risk is at what age did they start trying or did they start experimenting? The younger that age is, the more likely they are to go on and to develop a substance use disorder. This is just identifying and I'm going to go with knowing the people on in this group. I'm just going to go through these a little bit quicker. This is going to be dopamine and amygdala activities in a normal versus chronic heroin user. And you'll notice that the chronic heroin user has less pleasure and more anxiety, more stress, and just active living through that. And I think, a Pavlovian response explains the increase in anxiety very well. If I don't have my drug, I'm going to feel like blank. And just, I am out of money and already associating with it. I've had more than one patient who just having pocket change or the feel of money can be triggering to them. Again, that's a Pavlovian type response. Just as a reminder of the DSM-5 criteria here, we've got a loss of control, physiologic tolerances, and consequences. To me, I think as we're looking at our youth, well, we really want to kind of tailor some things to them, and this is the craft scoring system, and we're on the craft. They've redeveloped it into the craft too, just to things that sound alike and have the same acronyms. Evelyn has a talk on craft as well, but it's a completely different craft and a whole mindset, just for clarity. So with this, the one question that really comes is the highest yield, and our pediatric or child adolescent psychiatrists who are bored in addiction absolutely loves this first question. Have you ridden in a car with somebody, including yourself, who was high or had been using drugs or alcohol? That's such a big predictor because it does several things. One is, is it doesn't matter if it was an uncle, if it was a cousin, it was that person. If it was a friend, we're given the teen the out to say, hey, I've never driven a car drunk, but I was, and somebody else was driving. It also gives you a sense for who their peer group is. It also gives you a sense for who their adult mentors maybe or influencing. Again, getting a ride with a stranger is something we discourage starting at a very young age. And then we get into the next question of the R is for relax. And again, are we using this to cope with, I'm just stressed out. I had a bad day at school. And I'm just going to pick on Julie because she's not on very often, but Julie was picking on me again. And so I just need a drink to relax after that conversation. is really starting to get into that negative reinforcement pathway. And Julie, thank you for letting me pick on you a little bit. Um, this is a reminder of the different dimensions of care, and this is laid out by ASAM. So you're gonna some of my biases of an ER doctor is I think of my ABCs or my CAB my basics of when I'm resuscitating people. In the addiction clinic, this is my fallback and what I'm looking to do. I don't look at necessarily this as a prior as I walk through this and I prioritize what I'm going to do is what is the patient in front of me willing to what is the patient willing to work on, and where are we at? And if the person doesn't want to deal with their anxiety, their mental health, that's fine. We can move that to a different time or a different place, and we can start focusing on readiness to change, changing environment, etc. Um, this is, I guess, a little bit of a review of some other slides, but just really highlighting the survival benefit associated with medication for opioid use disorder. That I know of no parallel in medicine, at least by peer-reviewed randomized control studies as a standard. We're down. This is a slide that I lifted from the PCSS X waiver course that was reviewed at at my National College of Addiction, of and demonstrating with these three studies, putting together a 75-80% survival. When we look at bringing this back to the teen adolescent population, we're coming up on 9 years since the American Academy of Pediatrics published this position statement recommending first line for medication assisted treatment for adolescents with opioid use disorder. Some of the language I understand has evolved a little bit, but this is a document that I reference regularly as well. And one of the particular reasons that I do is buprenorphine is FDA approved down to the age of 16. Methadone is down to the age of 18. The double AAP paper does not specify an age. So what we believe is that if I've got a 14-year-old with a substance use disorder or with an opioid use disorder, that they are a candidate for medication, and not offering or withholding the medication probably isn't going to be providing the best of care. And I'll reference this document as source. Also recognizing the American College of Obstetrics and Gynecology 1 year later also put the positions that opioid use disorder for pregnancy is a first line treatment and improving birth outcomes and things. So again, this factors into our teenage pregnancy population as well. So I have struggled, and I think how do I teach is a proper induction on buprenorphine. And this is what I ended up doing. And I would be curious for y'all who are experienced if this makes sense. So number one is we've got the FDA approved method where we wait until the cow score is greater than 8 and then start with buprenorphine 2 to 8 milligrams. And we try to get the patient up to 12 milligrams on their first day. We're also FDA approved to start the depot injection on day 1. Now, if you've been coming to these sessions like Flavio, or half the time that Flavio is, you'll know that we oftentimes take an off-label approach to this. And I think in the fentanyl era, our hands are kind of forced to doing this. And because a lot of our patients, what we actually do is we induce opioid withdrawal if we do it too soon. A lot of our patients have struggled to get up to get that cow score up high enough that they can do the induction safely. And what has evolved over time, and based on some honestly, it's not the best quality data, but a tremendous wealth of anecdotal data, is just starting with a low dose induction approach. Starting on a day one of, I use a 0.5 milligrams once a day, and then 0.5 milligrams on the second day, and then basically double that dose every day for a week. And then at that point, I'm up to 16 milligrams. We can take a look at the induction. With our teen or adolescent population, we've got two child adolescent psychiatrists also boarded in addiction in this state. There's less than 400 of these guys in the whole country. And both of them really feel that the evidence supports a depot injection, whether it's Brixadi or Sublocade for our adolescent population, because our adolescent with that impulsivity, they don't forget to take their medication. They can't divert their medication. And it just improves overall compliance with it. And I think I've had enough adult patients who, they a month into it, 2 months into it, they're ready to come off of the buprenorphine. And our teens are, hey, I'm having a good day. I don't want to take my medications. Or we're going on a family trip to for the 4th of July, and oops, I forgot my meds. Or I didn't want to take it to school and I forgot my morning dose. It just prevents a lot of those situations from occurring. So with that, I'm just going to open this up to any questions that you guys have.